So today we brought you a presentation titled Racism in Sickle Cell Disease. And we have with me on the panel, we've got Esther from Ireland. She's the president of Sickle Cell Society in Ireland. We have Natalie, our board secretary, who's here with me in Melbourne. And we've got Caroline and Pikamezo all the way from Australian Sickle Cell Advocacy Western Australian chapter. And of course, we've got Dr. Ahmar Zaidi from Michigan, who's going to give an education session for us. My name is Agnes. I'm the co-founder of Australian Sickle Cell Advocacy, the leading organization looking out for people affected by sickle cell disease in Australia. And without wasting much of the time today, I'll give Dr. Z the floor to do the presentation. Thank you so much. We'll go into Q&A afterwards, and we can put our personal perspective for the other panelists after. Thank you.
Great. Thanks, Agnes. Okay, well, as Agnes alluded to, we are going to have a very important conversation today. We are going to talk about something that's really important, particularly here in the United States. So today we're going to talk about the battle for equality, justice, and respect, and the lessons that I've learned from the United States in sickle cell disease and racism. Again, my name is Ahmar Zaidi, at Dr. Z Sickle Cell for my social media. I love advocacy. I love talking about what's going wrong with the way we care for sickle cell disease patients and how we fix that. I love getting into good trouble. So that's sort of my special power. Here are my financial disclosures. So, often you guys probably hear this talk all the time. The first patient with sickle cell disease, Walter Clement Knoll, right? We hear about him all the time. It's always been striking to me, though, that Walter Clement Knoll is different from the typical sickle cell disease patient in America, right? The description of Walter Clement Knoll is this well-off Grenadian dental student who comes to the United States for advanced training. And he gets to the emergency room. Not only is he treated well, he's actually treated very well. He's actually given all the tests he needs and the tests that are extra, like somebody named Ernest Irons looking at his blood under the microscope. And that unlocks the crucial finding in sickle cell disease. But that's always bothered me because that's not the story of sickle cell disease, right? That's not what sickle cell disease looks like in America, at least. And when you dive into the literature a little bit more, you know that in 1910, Walter Clement Knoll's story is first published in JAMA. But you dive in a little bit more, and actually what you see is something a little bit more congruent with what we've come to expect of sickle cell disease. In 1846, there's a case report of the runaway slave. And this runaway slave, who was nameless, was found, convicted, and executed, and then taken to any surgeon that would demand for the body to have an autopsy done to study this person. During that autopsy, Dr. Levy, who was the pathologist, describes a man who was poor and unfortunate with leg ulcers and an absent spleen. The plantation owners described him as someone who was often irritable, had frequent fevers. And the reason that I make this point is because we can't talk about sickle cell disease without talking about racism, right? In the United States, sickle cell disease is present here as a direct result of the transatlantic slave trade period. This is the only country where that's true. And that's what makes this particularly complex and complicated, because the American healthcare system has been built on discriminatory and racist structures that have violated the African-American Black community in this country. We as healthcare providers have broken down the barriers of trust. We've broken the bridge of trust between Black patients and us. And this makes for a very, very different environment in which we're providing care for sickle cell disease patients. And it's not just sickle cell disease, right? The Black community suffers in this country from everything. There's a almost 16% higher death rate for individuals who are Black here, 22% more heart disease 13% more cancer, 40% more cerebrovascular disease, 90% more diabetes, right? So this affects every faucet. And we know that because when COVID hit, guess who died the most, right? It wasn't a surprise. The media pretends like it was a surprise, like, oh my God, all of these Black people and Hispanic people are dying. We don't know why. Well, we know why. So you see that there's disproportionate death. This is the representation of how many Black people there are in the state, in the gray circle, and how many Black people represented those who died in the green circle, right? Look at the difference here. The Black community disproportionately represented in the mortality statistics of COVID-19. But we know that Black lives don't matter in this country, right? We know that. And we get that reminder all the time, right? We see what police brutality, the killing of unarmed Black people in this country, the way that happens, the regularity with which that happens, we see all the time. It's our unfortunate regular reminder that we have not come far on the front of racial equity in this country. So on May 25th, 2020, when George Floyd says, "I can't breathe" 20 times in a span of 8 minutes, America woke up and said, wait a minute, Black Lives Matter. This is not okay. And sickle cell providers, the sickle cell community said, wait a minute, we've mattered for a really long time. We've been saying that Black Lives Matter for a really long time. So what I'm presenting to you today is that George Floyd saying, "I can't breathe" 20 times in 8 minutes is the same thing as my sickle cell patient in the hospital who's saying, "I'm in pain," and doesn't have someone to believe them, right? That's the same fight. It's just happening in a different place. So this was really just another day on the job for sickle cell patients in the sickle cell community, right? We were already behind this. This is not news. This is not fake news. This is real life. This is the real life of every sickle cell disease patient every single day. But what can you expect, right? From a healthcare system where, if we go backwards a little bit, 1851, a physician, Samuel Cartwright, a plantation physician, a physician in the South, comes up with a term called dysesthesia aethiopus. And this is a term that he coined to describe the thicker skin of his Black patients, a condition which makes them feel less, right? And can be corrected by stimulation in the form of whippings and beatings, right? This is a physician in 1851 in this country who's bringing this to the table. So what's the problem? The problem is that healthcare workers don't like to talk about their biases, especially their racial biases. And most people don't even know that they have racial biases. But every single study we know shows us that doctors have the same level of bias as the rest of the population. In fact, I'll share a personal story about myself. I, as you can see, am a minority. I'm a person of color. I grew up in Canada and in a multicultural environment. My father was a liberal socialist who really believed in people having more in common than not. We would have regular discussions about race and religion at our dinner table. About 4 years ago, I took a test called an implicit bias test to gauge myself. And that test gave me a shocking result. And I think that's the result that changed my entire career. I took an implicit association test to see if I had an implicit bias based on race. And what that test told me was I have a subconscious implicit bias that favors white patients. And that was eye-opening to me, right? Because it's something that I have never consciously thought about. But what that did was change everything about the way that I practice medicine, right? Because suddenly I recognized that I have a blind spot in my own vision. I have a blind spot that I need to be more careful about, right? When you're changing lanes in your car, you have that blind spot and you have to turn and look, right? You have to make an extra effort to make sure you don't crash into something. So what I found out is I need to make that extra effort with my sickle cell patients. I'm in the blackest city in America, in Detroit, 84% Black. There's no chance There's no way that I can have a bias that that changes the way that I treat my patients, even subconsciously, right? So the first step is recognizing your bias. And of course, we know that this is especially important in the sickle cell disease population because sickle cell patients are subject to unnecessary scrutiny. In 2005, a survey of 109 patients who were treating sickle cell disease found that the majority of physicians believe that attitudes toward opioid addiction result in undertreatment of pain, and that there's a disbelief of patients' report of pain severity, something every sickle cell warrior can tell you exists, probably worldwide. In 2014, nurses' beliefs about the extent of opioid abuse and addiction among patients was studied and found to be very negative, more negative than the physicians, in fact. And in 2014, of course, we know that the NHLBI, which is our biggest governing body from a sickle cell disease health regulation standpoint, an expert panel recommended opioid analgesia for severe pain. So you have physicians and nurses with negative attitudes towards opioids, and then you have the 2014 NHLBI guidelines saying give them opioids. You can see that we're building a really bad story here. This recent study in 2020 by Dr. Jacob in Indianapolis was very interesting. She gave a 23-question assessment of vaso-occlusive management to emergency doctors at her hospital. And in the 52 people who she sort of checked in with, many of them were physicians, but she also brought in nurses. She found that 54% of those providers said, I'm really comfortable treating sickle cell pain. And what she found is the more senior doctors and nurses were more likely to say they're comfortable treating sickle cell pain. But actually less than 10% of all of the people she surveyed actually knew what the recommended time is from triage to the initial medication administration. She also found that 75% of the individuals surveyed were using vital signs as an indication of patient's pain level. And what I can tell you is that in the United States, while we do have an opioid problem, the number of inpatient deaths from opioid overdose has gone up tremendously. But if you look at it by disease, by category, the deaths among sickle cell patients from opioid overdose were flat or near zero during that same time period. Sickle cell patients are not causing your opioid epidemic, right? Sickle cell patients are not responsible for the anti-opioid culture here. This is not something that is a big problem in sickle cell disease patients. But remember, it's more than pain. And it's more than interpersonal racism, it's structural racism, right? It's more than just that person you meet who's telling you you don't matter because of your skin color. It's an entire system that's built to suppress the health of minorities, right? And that's where really the trouble comes. That's a much more difficult battle. That's much more difficult to overcome. And look how that shows up in our mortality statistics. You see that when we look at what's happened to kids is wonderful. The mortality's down, things are better, but adults are still dying. In fact, their mortality rate is going up, right? This is still a huge problem. We have failed the adult sickle cell population. And Agnes alluded to this earlier, the disparity in funding is tremendous, right? We're talking about, if you break it down based on Dr. Strauss's most recent study in JAMA, if you break it down by numbers, sickle cell disease patients per individual affected get about $800, $900. Cystic fibrosis patients per individual affected get about $11,000, right? This is a huge disparity. How do you overcome that, right? Here's the data. These are the data that we're talking about. So look here, I lost my mouse. Here we go. Can you guys see my mouse? Yeah, okay, good. So look at this, total funding per person affected, $943 for sickle cell, almost $11,000 for cystic fibrosis. That's too big of a burden, right? That's too big of a barrier. That's too big of a hurdle to overcome. And you can see that that shows up in more medications, right? That shows up in more publications, more knowledge about this disease, right? This is a little bit old as far as a graphic goes. We know we have 2 more medications, but we're still behind cystic fibrosis, even though there's 70,000 less patients with cystic fibrosis in this country. We have a lot to do. And I feel like I've been a little bit of a downer, a little bit of a Debbie Downer here. But I want to assure you that not all hope is lost, right? If we look at the number of publications with the word sickle in their title, we can see that there's a growing interest. We can see that the tide is turning, right? And we can see from that first description of Walter Clement Noel to Linus Pauling and Lemuel Diggs and Dr. Charles Witt and Wanda Shirney's dad and the Black Panther Party and their work in the 70s, hydroxyurea, Endari, Adakveo, Voxelotor. We're in a new, this is a new frontier, right? This is a new era of sickle cell disease. The spotlight, even if briefly, is on us. This is a very important moment because how we behave in this moment is going to change how the rest of sickle cell disease looks for the future generations. If we take that spotlight and shine it bright and correct some of those issues that suppress minorities at a system level, that's the only hope we have for those next generations. There's dozens of drugs in the pipeline. Of course, we know about the curative therapies that are coming. You know, efforts like the ASH Clinical Trials Network, the CDC's sort of registry and surveillance program, and a community like you guys that's connected is how the future looks, right? This is the only way that we're going to make sure that sickle cell lives matter. But again, this American-centric view, this Eurocentric view is very limited, right? It's a very narrow view. Yes, we happen to be in Ireland and Australia and America, right? Our stories with sickle cell disease are very different, right, than those in sub-Saharan Africa and the Middle East and the Indian subcontinent. And I always like to remember that. I always like to end with that because it's really important to not forget that that's where the burden of this disease is, right? That's where we need to go if we're going to make a real difference. So we can't forget the warriors that are without support in those areas, and we should always keep that in the back of our mind. So how does it look going forward? What is the map? Well, this is from the NASEM report that recently came out, the National Academy of Science report, talking about what the skeleton looks like and the overarching issues that are going to actually drive change. And those are really identifying the research gaps, identifying the limitations in funding, correcting the workforce needs, and continuing advocacy. And this is going to take a lot of us. This is not something that's going to be easy to do. This is not going to be something that's going to be a quick fix. This is going to take generations, but we're going to get there. And that's what I have for you guys today. Again, I have a podcast called Cheat Codes, a Sickle Cell podcast, and we talk about this kind of stuff and have these discussions all the time. Please go ahead and follow that, subscribe to that podcast, follow me at Dr. Z Sickle Cell. Agnes, that is all I have for you. I wanted to save some time for this discussion that we're going to have now.
Yes,
and I'm excited to talk with the panelists.
Thank you so much. So at this point, I will give each and every one of the panelists today, just to give you a perspective about the topic before we go into a question and answer with Dr. Zaid. Can I start with you, Natalie, please? Thank you.
Okay, thank you very much, Dr. Zaid, for that great presentation. I think we've seen that many times, and it is pretty accurate about what is happening. Was particularly excited to come and speak about racism in ACD. The way, my perspective on it at the moment is basically that I do understand that in the American context, it is definitely racialized. And where we talk about where the biggest burden is, which is Africa and the Middle East and India, there is definitely a, I feel like it's issues in policy failure, you know, because when I look at the African continent, well, I don't think we're definitely not talking about, you know, racism in that context, but in I would say fortunately or unfortunately, because America is where the biggest population of ACD patients in the developed world resides. There is definitely that racialized lens that you have to apply to it, which unfortunately or fortunately as well drives a lot of the literature and even a lot of the advances worldwide. You know, even where Africa is dependent on that African context. But I feel like while I respect the challenges in a country like the United States, I definitely would also like to balance it with the other needs and challenges of lower income countries. So that's my bits over there. Thank you.
Absolutely.
Thank you, Natalie. Thank you for that perspective. Caroline, what's your take on the topic today?
Thanks, Dr. Z. But I would somehow, on a point, agree with Dr. Z that there is a bit of racism when it comes to actual patients with sickle cell. I personally can share a story which affected me, and it's not in a hospital, but it's more in the work field, because like we all know, sickle cell is not a very common disease here in Australia, and it's definitely something that people need to be made aware of how serious it can affect a person mentally, physically, just on any level. I was in a situation where I was working with a colleague who was having depression, so anxiety attacks. And it turns out that my supervisors or my employers would favor that person over my condition whenever I reported a scene, to say, I don't like being put in this situation because it's making me sick, or the stress is making me sick. I've got a medical condition and this is all the information you can find online, and this requires me to have less stress. But it was coming to a point where this person condition was usually much more understood than it was with my case whenever I reported a problem. So yes, it did feel like, because there's that lack or that gap of where awareness was still important for my employers to understand that my situation was just as bad as getting anxieties. And I mean, let's face it, sickle cell has probably got a combination of anxiety and a physical on a very high level compared to somebody who's just suffering from anxiety. Not saying that that's not as bad, but I'm just saying, if you look at both the cases, they definitely affect anyone on a very high level. So with that in mind, I think there is a bit of awareness that needs to be addressed, especially here in WA. I would say, yes, I've had issues with my employers to say, I have to every time address it to them that I have this medical history and these are the triggers. I would like to avoid these triggers as much as I can. And some will understand, some will not understand. But given a situation where there's two people with almost similar cases, I've always felt that my case was not as important as the next person. So again, yes, there is a bit of racism in it, and there is a bit of awareness required. So from my perspective, I think it's a bit of just covering all bases. And from history, I think with Africans, we tend to find that we're too reluctant to accept that this is racism, because we take on a lot and we're comfortable to say, yeah, maybe it's not racism, maybe it's just a bad day kind of person or kind of situation. So sometimes it is important to actually acknowledge that, yes, it is kind of racism, so accept it and then move on from it, or have a way to move forward. So yeah, in a way, I agree with Dr. Z. Thanks.
Okay. Thank you, Caroline. Thank you for that. Esther, what's your take on today's topic? You're mute, Esther.
Pardon me, I'm so used to muting myself. Agnes, as you know, I have a solid passion for this topic, and thank you for bringing it up again online. And where do I start from now? Yeah, I must thank you, Dr. Z, for that very elaborate presentation, and I would quite well agree with you on everything you have said there. The whole historical, conceptualization of sickle cell from, the time of slave trade and to the present day, and how, you know, racism had been systemically built in the structures of, you know, healthcare for people with sickle cell. I very well agree with you on that. And you also identified, you know, there are two views on sickle cell, of course, the Eurocentric view and the American story as well, if I'm right. Like Natalie said, there's also the African, you know, view as well. So we might want to agree there are three world views, put it that way, of, you know, how racism, you know, penetrates the care and management of sickle cell. I would very well agree, you know, that, where do I start from now? In Ireland, for instance, my children would have presented as one of the first cases in Ireland. And imagine coming into Ireland, being a Black person and presenting with a condition that is relatively unknown to the healthcare professionals. You know, the whole lack of understanding of the condition in its own created some form of barriers, which is still there systemically. It's still there because it does affect the way healthcare is distributed amongst, you know, people living with sickle cell in Ireland. The long waiting times, the less priority for patients in crisis compared to other conditions. For instance, if you stepped into emergency department, you're a cancer patient, you're given priority compared to a sickle cell patient. The same thing we're talking, the inadequate, you know, knowledge, the lack of education in training the condition and continuous, you know, professional development for the medical community. Not until, you know, recent years, through the works of this society, the Sickle Cell Society, sickle cell was just a textbook knowledge of maybe a line in our university until we worked so hard, you know, and a lot of our medical colleges now, you know, put in sickle cell on their curriculum. So you see, imagine, for instance, the Caucasian community treating a condition that affects a Black person without even having the knowledge medically. How do you treat that? This is where the whole bias and unconscious bias comes into play, because all you know is about conditions that predominantly affect white people, not conditions that affect Black people. So there's, to me, there's, you know, all of these little building blocks builds up the level of racism we experience in healthcare delivery. Healthcare delivery is one of it. And we talk about racism in education as well. I speak from personal experience. You see, one of my daughter would have to struggle so hard to either settle for lower grades or push herself so hard to pass her exams, or maybe, you know, miss the year. She missed like 2 years in school. And this is because we do not get the kind of support, you understand, say a patient that is suffering from a different kind of chronic illness would get. So you struggle so hard, you push yourself, and you know, you fall within a baseline because you have sickle cell. There are stories, untold stories of no awareness, the right access to disability services, the lack of support in terms of, you know, lack of, you know, the effects of attendance, appointments, and hospitalizations, and all of that. There's a whole lot of story. And there's also racism in employment. Caroline mentioned there, you know, about the effects of, you know, racism in employment, the lack of understanding of sickle cell when it comes to your employers. It's still a gray area. And Dr. Z, you talked about what do we do? This is where, you know, we have a lot of work to do. the lack of empathy, the lack of, the effects, this gives to patients living with sickle cell. I must also commend the work of Professor Simon Dyson. He's done so much in terms of trying to bridge that knowledge gap in sickle cell education and employment. And I suppose if we all can build or can, learn from the work he's done and use that framework across the globe, then we will be impacting knowledge. When we talk about Africa, the effects of racism in Africa, like Natalie said, I wouldn't call it racism as such, but I would merely call it discrimination. I call it discrimination because, speaking from, coming from Nigeria originally, when you have a child with sickle cell, it's a family secret. Nobody wants to talk about it because everybody else will either, there's that sense of feeling pity, or there's that sense of isolation, or there's that sense of you becoming, mockery of your community. And this is all coming from, part of some of the myths and misconceptions we have, where people that are born with sickle cell, because of lack of medical advancements in Africa back in the days, were being looked as, possessed, or there's what we call abiku, because they die very young, because they do not have the right access to care. So all of that, discrimination now builds up in the wider society. Because of discrimination, they lack the right access to healthcare. There is no proper policies in place to deal with all the issues that, involves, delivering the right, services and treatment protocols to people living with sickle cell. So it's, I don't know where we're going to start. Like, it's just all over the place. And what do we do? I suppose this conversation today, should focus on how do we move away from what we already know? What are our goals, and how do we get
Yeah,
there?
exactly,
Thank you.
Esther. I think that those are very, very important points that you put out there. I think at this point, I wanted to ask Dr. Z, like, where do we start from? I know this is a very uncomfortable discussion, and as you've said with what Caroline said, sometimes we tend to, when you've sort of, especially for those people that have experienced it so much, you tend to just, sort of brush it aside. For me, I've had a discussion, and I think Natalie will attest to this. The time when we had this Black Lives Matter, coming up, especially in America, our board secretary, our board chairperson asked us this question, and I told her that for me, I sort of try to protect myself. I'm a very passionate person about things, and when I get passionate about something, I actually get physically sick. I won't even eat. That's how bad things become. So I sort of try to protect myself and not dwell so much into the issue about racism. There's a term that I always tell my husband, he always laughs, that at this point in life, I've just given up, such that I've got questions, and the only person who can answer those questions for me is God. That's where I've said, I've given up. So I tend to sort of protect myself, and I didn't share anything because I was trying to protect myself, because the more I dwell into it, the more depressed I'll get. So we had a very good open discussion, and this board chairperson of us, Dr. Margaret Evans-Kalia, is a white person who's very passionate about Black people, and she's bringing those discussions to be discussed in the workplace in Australia. So as individuals, Dr. Zaid, what can we do to break this gap and bring these uncomfortable discussions? What should we do?
That's a wonderful question, Agnes. But before I get to your question, I want to thank Caroline and Natalie and Esther for their really, really nice points. And I want to speak really quickly to what Esther was talking about before we get to your question, Agnes, which is the stigma, right? The stigma that exists within minority communities. I'm sure the African community, similar to the Indian subcontinent, like you mentioned, illness is looked down upon in our community, right? It's not something that you publicly share. It's not something that's always out there. There's a big concern about What will others think, right, in these communities? And you know, growing up in that type of environment myself, I really do understand that. I think that when I talk to my patients here, you get the sense that there's a lot of stigma within families where sickle cell patients actually feel like their family is other sickle cell patients, because those are the only people that get it. That's the feeling I get, especially from my adolescent and teenage patients. There's a big gap, it feels like, with my teenage patients and the rest of their well family sometimes, because it feels like they can't make their family understand what they're feeling. I also think that there's a little bit of personal stigma. I think sickle cell patients sometimes stigmatize themselves, which is something that's really important to change, right? Is how do you stop thinking about your own condition negatively, right? I think that really influences your well-being, because if you think about your condition as not a defect in hemoglobin, but actually a way that humanity survived, right? A way that humanity existed despite malaria, a superpower, right? That allowed for humanity to carry on in sub-Saharan Africa. This is a mutation that was part of an evolving human population, right? This is a win. And I think that positive tone really makes a difference in patients, because sometimes I feel like patients stigmatize themselves. Okay, now what do we do about this? How do we fix this? So the first thing is, for me, I have stopped worrying about other people's feelings, right? So as a Canadian, that's very hard, because as a Canadian, we're always saying sorry to everybody. But if I feel like something is being handled poorly, if I think that there is a bias that's coming out, if there is a prejudice that's coming out, I'm going to talk to you about it. We're going to have that conversation, because this is not the time to spare people's feelings. This is the time to make people better. And those uncomfortable conversations need to become regular in our day-to-day movements. We have become really comfortable with letting things go. And I think that's got to stop, right? We can't have that anymore. That's number one. The second thing is holding institutions accountable. We always talk about sickle cell patients needing to advocate when they're in the ER about being believed about pain. Advocating with your institution when you're well is very important. Go to them, talk to them about what they've put in place to reduce implicit bias, what they've put in place to help sickle cell patients feel welcome and appreciated. Have those conversations outside of the time of your illness. 2. 3, the workplace. So that one is more challenging. That one is more broad, right? How do we affect how schools and the workplace think about sickle cell disease? That one's going to be challenging. What I can tell you is knowing somebody with sickle cell disease is the first step, right? The fact that someone like Caroline or Esther, has interacted with people in their workplace is the first step, because then those people can say, I know somebody with sickle cell disease, right? And that's the first way forward. I think putting yourself out there, I think being open about the fact that you do have sickle cell disease and you're fully functioning parts of society that are contributing, that are doing amazing things. When your body's not trying to slowly kill you from the inside, you're able to do amazing things in this world. I think people seeing that, people understanding that is going to be the way to go forward. I don't think there's going to be a quick fix to this, Agnes. I think this is something that we have to internally, just as a community, understand that we're going to have to break this down slowly over time.
You know, the other thing that I wanted to, again, talk about being an advocate and bringing in those uncomfortable discussions. And there's me again, bringing the story of hydroxyurea and other drug companies. Like, how do we take on and not being afraid as advocates? Because if you open your mouth, for example, then you are risking that you are not going to get funding, for example. How do we take on companies who, for example, I know Bristol Myers Squibb, the moment hydroxyurea became on the market in the 1990s, obviously they knew where this huge amount of income came from when people of living with sickle cell disease started purchasing hydroxyurea. How come it actually hasn't changed much? And I'm naive enough, I went on LinkedIn to ask a hematologist, like, why didn't they make like small doses? Because even up to today, we have this problem that they can't make smaller doses for hydroxyurea for sickle cell patients. And the same answer that I get all the time is that it's not meant for sickle cell disease. Could that be the reason why? Again, because this disease affects the minorities. And for example, the majority of patients that are affected by sickle cell disease are in Africa, where unfortunately, and I think this is one of the things that this lady from Forbes also talked about. This article was written in 2015, unfortunately. So I'm talking about this from the point of view of 2015, when she said the issue she had for years with hydroxyurea, noted that she indicated that hydroxyurea was approved for adults for sickle cell disease in 1998. 30 years after its approval for chemotherapy. However, as of 2015, there was still no pediatric formula because there was no commercial interest in developing one despite the need. So I'm just, can I just say, could that be the reason why, Dr. Zaid, that such things could be happening? Yes or no?
Yes, absolutely, 100%. This is, until it's proven to me, this is a racially and economically driven field in its entirety. Okay. And yes, there are companies that care. Yes, there are companies that support the community. But in the end, this is always in people's mind going to be a minority disease. This is always going to be a Black disease, right? And that's how people are always going to frame it. And it's up to us to change their mind. And I could make the point, Agnes, that yeah, you can be fearful of what you say, but who do you think is a bigger brand right now? SCD Talks with Agnes or Bristol Myers Squibb? I would make the argument that Agnes is a bigger brand for the sickle cell patients, right? And that's a huge power to have, to be able to say, I can change people's minds on something, and BMS can't. Yeah, they have money, but they don't have influence. And I think that we underestimate our ability to make changes. But I think that being open and outspoken and advocating without fear is so important. I mean, we have to hold people accountable. We have to ask tough questions. That's the only way we're going to get to the right place.
Thank you for that, Dr. Zaid. I know the time is running out. Naturally, I'll give you the spot. I've got so much things to say about this topic, but I'll keep quiet.
Okay, so I'll try to be short. So my point with this is I'm a bit more of a cynic and a practical person. So when I think about it, I'm thinking, okay, companies like Bristol Myers, as unhappy as I am with the state of what they are doing, definitely they should know that, if they have this much money coming into their coffers, surely it does come from somewhere. At the end of the day, I also understand, they're a company that is out there to make money, whether we like it or not. Whether there are people who are affected, and in terms of influencing how they operate, where I look at it, I mean, as we all see, the largest burden is in Africa. I would like for African policymakers to be made more accountable, because they do have goals which are tied to sickle cell disease as a public health issue. And I think even in terms of the Millennium Development Goals, they do have measures which they are not respecting, because if they would actually lend some weight to these issues, it would mean that a lot more people would get access to basic care, comprehensive care. And yes, we could even have deals with BMS, with Bristol Myers Squibb or whoever, and make sure that people are well taken care of. At the same time, I definitely do encourage us to keep on speaking, whether it's putting BMS's feet to the fire or policymakers. I'm all for it, because I just feel that it is time that the little person is not out there fighting on their own. We all belong to a community, to a country, to a continent. I feel that it is time for those people to step in and step up. So
thank you.
Natalie, Agnes, do you mind if I make a point to Natalie's point as well?
Yes,
really
yes,
quickly?
Please.
I'm sorry. Look, we're now in a situation, at least in the United States, where we have 4 approved therapies for sickle cell disease with gene therapy around the corner, okay? Who's responsible for those therapies? You could say it's the company, but I make the point that those companies they cannot get those therapies studied or approved without you.
The sickle person.
Right? It requires you. It requires your blood as a sickle cell warrior. That's where the answer is, right? And when you have that type of power, you control the equation, right? So I think that we cannot underestimate the power of sickle cell warriors' participation in these companies getting drugs approved and getting to answers, right? So when you have that type of power, you should use it, and we should use that to build up our community, build up what we can do for our community, build up our advocacy efforts, and really, like you said, hold their feet to the fire.
We are almost running out of time. Caroline, please, just what do you think about what we are discussing now? Please throw in before we let Dr. Zaid go for work.
Yeah, sure. Thanks again. I actually think it's really important, like how we're all putting it, to say we need to make as much noise as we can. And the more noise that we raise, the more we become noticed, and we will push something to happen. Because I mean, look at hydroxyurea. It's been a drug that's been known for a very long time. There's some other drugs that are being developed probably in America that in Australia we're not aware of. So the more noise we make, the more they'll notice that this disease needs to be looked at, because without even raising those concerns, they'll just think it's just a disease that is just there, will come, will go. Probably what Trump thinks about COVID. So I'm not going to about that. But thank you so much.
Well, this topic, I think we just have to come back on either the Sickle Cell Talks with Agnes or either the Amplify series. It's a very important topic to discuss, and I tend to hold off and let people talk. It's a very very, very sensitive topic, but it's a good topic to discuss. So Dr. Zaid, thank you so much for coming on. An hour has gone so quick. So unless you girls have got something to say, I'll let Dr. Zaid go, because
can I say something before he goes? Because in fact, now that we have him, I just need to put this out there. Dr. Zaid, you said the system is racially and economically driven. I want to add one more thing there, politically as well, because when we look at, I know very much, I agree with you that the power is in the advocates' hands, to make the demand. However, Dr. Zaid, I have been following your work, and I see that as a physician, you take a different standpoint. I've always had this hypothesis that physicians have more influence or power, whether politically or economically, to drive the innovation of precision medicine for sickle cell. However, because it may not favor them, there is not much benefit. For instance, if the physicians advocate for sickle cell community to be funded fully, okay, look at the disparity you talked about between cystic fibrosis and sickle cell, $900+ as opposed to over 10,000, dollars or whatever, if those figures are clear. So my point is, if the physicians can mobilize with the patients or take a standpoint with the patients, I think that is where the power and the influence can drive things to happen. But because economically, it will not benefit them. Take, for instance, countries that don't have bone marrow transplants, why can we not introduce bone marrow transplants at birth, just as much as, you know, they have introduced bone marrow transplants for patients with what's
leukemia.
the cancer? Leukemia. Exactly. Why can that not be the case for sickle cell? It's because
but Esther, if we had 100 Dr. Zaids in the country, in the world, that could happen. Yeah, if we had even 10 of him, that can happen. But unfortunately, we don't have people that are like him, and that's why I think we should be portraying this message to say, you know, this is what we expect from our physicians, and how can we work together as advocates. I'm really mindful of time. It's a working day today, so I'll let Dr. Zaid go. If you guys want to stay on, you can continue the discussion. But Dr. Zaid, I'll give you the last word, please. Thank you.
So thank you for having me here. Thank you for taking time to hear me speak. I really appreciate the invitation, Agnes. Look, sickle cell disease is a back of the bus disease, okay, for patients, but also for doctors. So yes, patients and doctors need to combine, work together to amplify their voice. But remember, you might have a doctor in Ireland or wherever you are, whoever's listening to this, you might have a doctor who's a champion for you, who when they walk into their administrative suite at the hospital, they get looked at the way a sickle cell patient does when they walk into the ER, right? When a sickle cell doctor walks into the administrative suite, they're just the sickle cell doctor. They're not the surgeon. They're not the cardiologist. They're just the sickle cell doctor. This fight is happening at every single level, right? So it's a really different story when a surgeon goes and asks for another social worker, the cardiologist goes and asks for another nurse. And if I go and say, hey, I have 800 patients, can I get one more nurse? I take care of poor Black people, right? So that request, it goes a little bit differently. We have a lot of work to do, but you're right. I think if we amplify our voices, we work as a team, we can get there. But we're all fighting this battle in different places. So don't take inaction as not trying. Some of that inaction is also providers who are stuck in a cage of structural racism that's keeping them from spreading their wings.
Thank you.
Okay.
Thank you for
well,
that.
thank you, everybody. I have clinic, so I'm going to run now, okay?
Yes, yes. Thank you so much, Dr. Zaid.
Take care.
Hearing you.
Yeah, good to see you.
Thank you.
Thank you.
Bye.
Okay, bye. Well, ladies, there you go. We are still live on Facebook. If you've got your last session, I know Natalie, you still have something to say. What did you want to contribute after that?
Pardon? After what?
After Dr. Zaid's take.
It was really it was interesting. I mean, there's nothing that he said that was that was new. I think we all well versed in all of that, and maybe, you know, our experiences across the world might be slightly different, and that's where we definitely want more, you know, uniformity in terms of guidelines. You know, how people are treated. That, you know, one can expect the same treatment as anyone whenever they walk into an emergency department, whenever they need care. And of course, it's, you know, even issues around education, work, and all of that can only really change, you know, unless, you know, as long as we keep on having these discussions, you know, the more awareness there is to it. So that will help a lot. And I think that it's the same issue, for example, with stigma and discrimination, because when you see a lot of it is really rooted in ignorance and lack of knowledge. And in order to, to break those blocks and those barriers, we definitely need a lot more people, to come on board. It's good, for us to keep on talking, but in order for frameworks and structures to actually change, we need to hold some people's feet to the fire. That's just, that would be my contribution to it.
Yeah, well, I do agree, because we definitely are the minority when you talk about Africa. Like, for instance, my case wasn't discovered until I was 3 years old, and there was no research, nothing to actually tell my parents that your daughter is born with sickle cell anemia. So if we have the resources, the screening and all that stuff, because if you look at Africa, I don't think a lot of people are that much aware that this is the disease that's affecting their little kids. They've got kids being raised up without even the knowledge that they're suffering from a sickle cell anemia disease, which can potentially kill them if they don't do this treatment. So unless we've got those resources where we can actually say, we've got enough resources to do the screening, we've got enough resources to give them advice, then there's no getting over this disease without having that knowledge.